Hi friends, welcome back to the channel. Today we are going to discuss a very important topic in endocrinology, that is hypoglycemia. Now this is important to study because sometimes this condition can even be life threatening. You can check out the Internal Medicine Revision Series course on MediLectures app, which has high yield revision videos. A complimentary workbook hard copy will be provided to you. There are daily schedule based tests, WhatsApp group membership, and more than 150 tests with explanations from the Harrison's textbook. Now we are going to launch a 75 hard day challenge from 11th of July, which will last till September, from 11th July till September, and winners will get the exciting prizes. So you can also check out this challenge. For this you can use code 75hard for maximum discount, and we will be covering 4 units, that is pulmonology, rheumat, hemat, and gastro in these 75 days. In this lecture we will discuss first what is hypoglycemia, what are the various causes of hypoglycemia in adults, regulation of blood glucose levels, then what are the clinical manifestations by which patients present, why hypoglycemia is dangerous, then we will discuss individual causes of hypoglycemia in diabetics, then in non-diabetics, certain inborn errors of metabolism leading to hypoglycemia, finally approach to a patient, and after this you can assess your knowledge which you have gained from this lecture with the help of certain MCQs. So what exactly is hypoglycemia? So hypoglycemia simply means decrease in blood glucose levels. So what is the cutoff? Now most textbooks say that if the blood glucose becomes less than 70 milligram per deciliter, it is hypoglycemia, and it is also considered as level 1 of hypoglycemia. On the other hand, if the levels become less than equal to 54 milligrams per deciliter, it is considered as level 2 of hypoglycemia. Now, hypoglycemia may be documented by Whipple's triad, or better to say, Whipple's triad must be fulfilled to diagnose hypoglycemia. It includes symptoms consistent with hypoglycemia, which can be neurogenic symptoms and neuroglycopenic symptoms, which we will discuss later. There should be low plasma glucose concentration at the time of symptoms, which should be measured with the precise method. And finally, there should be relief of symptoms after the plasma glucose is raised, either by oral or parenteral glucose therapy or by glucagon therapy. Now, according to the blood glucose levels, we have 3 levels of hypoglycemia. As we discussed, level 1 is less than 70 milligram per deciliter. Level 2 is less than equal to 54 milligram per deciliter. Level 3, also known as severe hypoglycemia, is any episode which requires assistance of another person. Now this assistance can be required to actively administer carbohydrate or parenteral glucose or glucagon to the patient. So any level of hypoglycemia which requires assistance of another person is level 3 or severe hypoglycemia. Now what is the most common cause of hypoglycemia? Definitely it is the use of insulin or insulin secretagogues like sulfonylureas in patients of diabetes. So these are the most common cause of hypoglycemia. Now let's see the classification of hypoglycemia. So there are certain definitions. Firstly, we have discussed that severe hypoglycemia or level 3 hypoglycemia is any blood glucose levels which require assistance of another person. Then documented symptomatic hypoglycemia. What does this documentation means? That we have measured blood glucose at the time of episode. So documentation means we have measured the blood glucose. Also the patient was symptomatic. So typical symptoms along with blood glucose less than equal to 70. Then what is asymptomatic hypoglycemia? Patient is not symptomatic but blood glucose are less than 70. What is probable symptomatic hypoglycemia? Patient had typical symptoms of hypoglycemia but the documentation was not there. Patient was not able to check its blood glucose levels. What is pseudo hypoglycemia? Patient is having typical symptoms, but blood glucose on measurement is more than 70 milligrams per deciliter. Now, this can occur in diabetic patients who have highly uncontrolled blood glucose levels. Let's suppose that a patient of diabetes has blood glucose in ranges of 250 to 300 milligrams per deciliter. So, for this patient, sudden reduction of blood glucose to even 100 to 125 milligram, let's say, can produce symptoms of hypoglycemia. So, this is known as pseudo hypoglycemia. Now, let's see what are the various causes of hypoglycemia in adults. So, first let's see what are the causes in ill or medicated individuals. So, definitely the most important cause is drugs. So, in diabetics, use of insulin or insulin secretagogues are the most common cause of hypoglycemia. Patient who is chronic alcoholic can develop hypoglycemia as alcohol inhibits gluconeogenesis. Then other drugs like fluoroquinolones, quinine, ACE inhibitors, etc. can also lead to hypoglycemia. Now, after drugs, we have to consider the critical illnesses. Critical illness like hepatic failure, renal failure, cardiac failure, sepsis, inanition, all these can lead to hypoglycemia. Hormone deficiency. Now, since cortisol, growth hormone, glucagon, epinephrine, all these are counter-regulatory hormones, so their deficiency makes patient prone to develop hypoglycemia. Then we can have some non-islet cell tumors like mesenchymal tumors, basically some epithelial tumors. These can also lead to hypoglycemia. In these, insulin is reduced. Insulin is reduced as a counter-regulation. So what is leading to hypoglycemia? It is improperly processed IGF-2 molecule which acts on insulin receptor, leading to hypoglycemia. Now, in seemingly well individuals, there is relative insulin excess which is leading to hypoglycemia. Relative insulin excess. Now, what can be the causes? There can be increased production of endogenous insulin. So, there can be a beta cell tumor known as insulinoma. Then, functional beta cell disorders in which there is hypertrophy, hyperplasia of beta cells, but these do not produce tumor. This pattern is known as nesidioblastosis. So, this is also termed as non-insulinoma pancreatogenous hypoglycemia. Post-gastric bypass hypoglycemia also does by similar mechanism. Then there can be insulin autoimmune hypoglycemia. There can be antibody to insulin receptor which activates the insulin receptor. There can be accidental or malicious intake of insulin secretagogues, some other causes. Then there can be certain disorders of gluconeogenesis, glycogenolysis and fatty acid oxidation. Exercise induced hypoglycemia because it leads to insulin independent glucose uptake in the muscles. Then accidental, surreptitious or malicious hypoglycemia. Now we will discuss each of these causes in detail, but before that we'll have to understand the regulation of blood glucose levels in the body. Now, as we all know that glucose is an obligate metabolic fuel for brain, because brain cannot synthesize glucose or store more than a few minutes supply as glycogen. Brain requires continuous supply of glucose from arterial circulation. For this, blood glucose levels must be tightly regulated and must be maintained in a range which is sufficient for utilization by brain as well as other tissues. For this, fasting plasma glucose are maintained within a relatively narrow range of 70 to 110 milligrams per deciliter. This is basically done by endogenous glucose production, hepatic glycogenolysis, which is breakdown of glycogen to glucose in liver, and finally hepatic as well as renal gluconeogenesis, which is formation of glucose from precursors like amino acids, fatty acids, lactate, pyruvate. Now let's discuss what are the physiological responses to decreasing plasma glucose concentration. So the first defense against hypoglycemia is decreased secretion of insulin from the body. As we all know, insulin is an anabolic hormone. It inhibits glycogenolysis. it inhibits gluconeogenesis normally and increases the uptake of glucose by peripheral tissues. These are the normal functions of insulin. Now, the insulin levels start falling when the blood glucose levels reach 80 to 85 milligrams per deciliter. Now, hypoglycemia has not developed, but first mechanism by which it starts tackling the antecedent hypoglycemia is decreased insulin secretion from the pancreas. So, if the secretion is decreased, what will be the effects? There will be increased appearance of glucose in blood. There will be increased lipolysis, increased free fatty acids, glycerol. This will lead to gluconeogenesis. As the precursors are released, this will lead to increased gluconeogenesis, also will stimulate glycogenolysis and decrease uptake of glucose by the peripheral tissues. So it is a primary glucose regulatory factor or first defense against hypoglycemia. Now second defense is increase in glucagon. Now this only acts on liver, increases glycogenolysis and its levels start increasing when the blood glucose levels become 65 to 70. So at 65 to 70, two mechanisms start: increase in glucagon and increase in epinephrine. So epinephrine is the third defense against hypoglycemia and it becomes critical when glucagon is deficient. So we'll discuss that in type 1 diabetics who are taking exogenous insulin as well as advanced stages of type 2 diabetes, this epinephrine mechanism is very important as first two mechanisms are knocked off. So this will again lead to increased lipolysis, increased free fatty acid and also stimulate gluconeogenesis as well as glycogenolysis. Now after that, if the hypoglycemia is prolonged for more than 4 hours, this will also lead to release of increased cortisol and growth hormone at the same blood glucose levels. This is typically involved in defense against prolonged hypoglycemia but is not a critical mechanism. Symptoms of hypoglycemia, which we'll discuss in coming slides, typically occur at levels of 50 to 55. These include prompt behavioral defense against hypoglycemia like food ingestion. Decreased cognition occurs when the levels become less than 50. At the levels less than 40, seizures and coma can develop, and at the level less than 20 milligram per deciliter, brain death will occur. So these are the physiological defenses to hypoglycemia. So let's summarize the actions of various hormones. So what is the normal action of insulin? In liver, it inhibits glycogenolysis and gluconeogenesis. In kidneys, it inhibits gluconeogenesis and it increases glucose utilization by the peripheral tissues. So decreasing insulin levels, which is the first defense, will lead to opposite actions, that is, will increase glucose production from liver, will increase glucose production from kidneys and will decrease the glucose utilization by the peripheral tissues like adipose tissue, muscles, etc. Normal action of glucagon is only on liver, where it stimulates glycogenolysis as well as gluconeogenesis. So it is the second line of defense which will lead to increase in glucose release from the liver. Then epinephrine, which is the third defense, will act again on all three mechanisms, that is on liver, kidney as well as decrease the utilization by the peripheral tissues. Now it is interesting to note that the thresholds at which these physiological responses occur are dynamic, and these cutoff values which we discussed are not same for everyone. So these thresholds can shift to higher than normal in patients who have poorly controlled diabetes. In patients who have poorly controlled diabetes, so these patients can experience symptoms of hypoglycemia when their blood glucose levels decline toward the normal range. On the other hand, there can be shift to lower than normal in patients who have recurrent hypoglycemia. So typically a type 1 diabetic patient who is on exogenous insulin, who have recurrent hypoglycemia, can have lower threshold for these physiological mechanisms. So these patients become used to the lower blood glucose levels and become symptomatic only when the blood glucose levels are way too low compared to the normal healthy individuals. On the other hand, this first setting is fitting in definition of pseudo hypoglycemia, and this second example is fitting in definition of asymptomatic hypoglycemia. Now this diagram will help to understand and summarize the physiology of glucose counter regulation. So when there is hypoglycemia, that is decreased arterial glucose levels, the first defense is decreased insulin secretion from the pancreas. So this decreased insulin secretion, what this will do? This will increase glycogenolysis as well as gluconeogenesis in the liver. Along with this, this will also stimulate gluconeogenesis in kidneys. And thirdly, there will be reduced uptake of glucose in the peripheral tissues. Second defense is increase in glucagon. Now this is important to note that increase of glucagon from alpha cells occur only when the insulin levels are falling. So this decrease in insulin level is sensed by alpha cells, which then lead to increased glucagon secretion. Now this glucagon will act only on liver and will lead to increased glycogenolysis and increased gluconeogenesis. At the same time, brain will increase the sympathoadrenal outflow. This will stimulate adrenal medulla to release epinephrine. In sympathetic postganglionic neurons, there will be increased norepinephrine as well as acetylcholine. So this increased epinephrine is the third defense against hypoglycemia. This will again act on liver, kidney as well as peripheral tissues. Now this epinephrine release and norepinephrine release leads to typical adrenergic symptoms of hypoglycemia, while these acetylcholine release leads to cholinergic symptoms of hypoglycemia, one of which is hunger. So due to this hunger, which is also a behavioral defense against this condition, the patient ingests sugars, carbohydrates, leading to increased arterial glucose. If the hypoglycemia is prolonged more than 4 hours, then in brain there is increased secretion of growth hormone as well as ACTH, which will finally lead to increased cortisol. So these growth hormone and cortisol are the fourth defense against hypoglycemia. Coming on to the clinical manifestations. So what can be the various symptoms and signs of hypoglycemia? So when we consider symptoms, there can be neuroglycopenic symptoms or neurogenic symptoms. Now neuroglycopenic symptoms of hypoglycemia are direct result of CNS glucose deprivation. These features include behavioral changes, confusion, fatigue, seizure, loss of consciousness, cardiac arrhythmias, which can even lead to death if the hypoglycemia is severe. On the other hand, neurogenic symptoms are the autonomic symptoms associated with hypoglycemia. These can either be adrenergic or cholinergic. Now, adrenergic symptoms can be remembered by TAP, that is tremors, anxiety, palpitations. These occur due to release of norepinephrine from postganglionic neurons, and release of epinephrine from adrenal medulla, as we have discussed in the chart. Then cholinergic symptoms can be remembered as HSP, which is hunger, sweating and paresthesias, and this hunger is very important defense mechanism against hypoglycemia. Now as we can see that all these symptoms are somewhat non-specific, so their attribution to hypoglycemia requires that the Whipple stride must be fulfilled. So at the time of symptoms, the corresponding blood glucose levels should be low and there should be resolution of symptoms after the blood glucose levels are increased. So this is a very important point. Now what can be the common signs? These include diaphoresis, pallor, increase in heart rate, systolic BP. Now neuroglycopenic manifestations can be observed. Transient focal neurological deficits are common, but rarely permanent focal neurological deficits can also occur. So we are talking about hypoglycemia, But why is this hypoglycemia dangerous? Not only hypoglycemia results in acute morbidity and mortality in patients, but repeated hypoglycemia in type 1 diabetes, type 2 diabetes, as well as in non-diabetic individuals leads to activation of pro-inflammatory, pro-coagulant, pro-atherothrombotic responses, which results in increase in platelet aggregation, decrease fibrinolysis, and increase intravascular coagulation. All this leads to increased cardiovascular as well as cerebrovascular morbidity and mortality. That is why hypoglycemic episodes must be reduced as much as possible. Other than this, hypoglycemia also reduces protective nitric oxide mediated arterial vasodilator mechanisms. Now, after all this discussion, we'll come to discussion of first hypoglycemia in diabetic individuals. Then we will discuss the causes of hypoglycemia in non-diabetic individuals. So hypoglycemia in diabetes is a limiting factor in glycemic management of diabetes. So basically we can consider that intensive blood glucose control is a double-edged sword. Basically it will decrease the microvascular complications associated with diabetes, but at the same time there will be increased risk of hypoglycemia. So these microvascular complications are dangerous in long term, but even a single episode of hypoglycemia can take the life of the patient then and there. As the patients with type 1 diabetes are treated with insulin as the initial treatment, the risk of hypoglycemia is more in such patients. So these patients have 2 episodes per week of symptomatic hypoglycemia and at least 1 episode per year of severe disabling hypoglycemia. Now, hypoglycemia is the cause of death in 6 to 10% of type 1 diabetes patients. Now, obviously, the incidence of hypoglycemia is lower in type 2 diabetes, but we more commonly see patients of type 2 diabetes presenting with hypoglycemia as its frequency is more than type 1 diabetes. Now, it is important to note that hypoglycemia can occur at any HbA1c levels, but it is more frequent at lower HbA1c levels. So, this is easy concept that HbA1c levels tell us about the long-term glucose control. This has nothing to do with hypoglycemia and hyperglycemia in the short term. Then, as we have discussed, hypoglycemic episodes are associated with increased cardiovascular as well as cerebrovascular morbidity. Now, what all drugs which are used in diabetes are implicated in hypoglycemia? So, very simple, insulin and insulin secretagogues are the one which can lead to hypoglycemia. These secretagogues include sulfonylureas as well as glinides, rapaglinide, nitaglynide, etc. Now, other anti-diabetic drugs like metformin, thiazolidinediones, alpha-glucosidase inhibitors, GLP-1 agonists, DPP-4 inhibitors, SGLT2 inhibitors, they will not cause hypoglycemia independently, but can increase the risk of hypoglycemia when these are combined with insulin or secretagogues. Now, it is very important that we must always try to improve the glycemic control incrementally. We should never target to control the blood glucose levels very rapidly. Now, there are various clinical trials like ACCORD trial, ADVANCE trial, UKPDS, VADT trial. All these trials have suggested increased risk of hypoglycemia in patients who were targeted for more intensive blood glucose control. In fact, ACCORD trial was terminated early because of mortality and morbidity in patients in the more intensive blood glucose control arm of the trial. Now, let's see what are the risk factors associated with hypoglycemia and diabetes. So, the conventional risk factors for hypoglycemia are identified on the basis of absolute or relative insulin excess. So, either there can be absolute or relative excess of insulin. Now, these include increased, ill-timed or wrong insulin or secretagogue dose. So, what this means, ill-timed, suppose a patient has injected regular insulin and skipped his meal or maybe consumed his meal 2 hours after the injection. Wrong insulin. At bedtime, patient was asked to inject long-acting insulin but injected ultra-short-acting insulin as both were available in pen. So this can be commonly seen in patients with type 1 as well as type 2 diabetes. So this can lead to hypoglycemia. Decrease exogenous glucose, which can occur with overnight fasting, intermittent fasting, missed meals after taking medications or insulin injections. There can be increased insulin independent glucose utilization during exercise. There can be hypoglycemia due to increased insulin sensitivity, which occurs with improved glycemic control. Middle of the night, there is increased sensitivity to insulin. After exercise, also the sensitivity increases. And patients who are doing weight loss and have recently increased their fitness, these patients also becomes insulin sensitive. So we have to reduce the doses of insulin as well as oral hypoglycemic agents. Then decreased endogenous glucose production, we have discussed in patients of chronic alcoholism. There is inhibition of gluconeogenesis. So this can also lead to hypoglycemia. Reduced insulin clearance, which can occur with renal failure in patients of long-standing diabetes. This can again lead to hypoglycemia. Now, after we have discussed the risk factors, there is something known as hypoglycemia associated autonomic failure. Now imagine this. All the above factors which we discussed are typically resulting in hypoglycemia. But what if a patient is not able to recognize the symptoms of the same? This becomes a deadly situation, as patient can end up in hypoglycemia again and again without being symptomatic. Patient will not be able to consume carbohydrate as behavior defense mechanism symptoms, these are all lost. So this is known as hypoglycemia associated autonomic failure. This can occur due to defective glucose counter regulation, which comprises physiological defenses. So physiological defenses are lost. What were these defenses? First defense was decreased insulin. Second was increase in glucagon. And third was increase in epinephrine. So if these physiological responses are lost, and secondly, hypoglycemic unawareness. These include loss of behavioral defense. Behavioral defense. That patient is not having hunger and cholinergic symptoms, so unable to take the carbohydrates. So this becomes a very dangerous situation. We'll discuss it in detail. Now let's understand hypoglycemia associated autonomic failure with the help of this flowchart. So in patients of type 1 diabetes as well as long-standing type 2 diabetes, there is absolute beta cell failure, and we have started the patient on insulin therapy. So we are giving him exogenous insulin. Now suppose the insulin dose is high or the patient has skipped his meal. There will be development of hypoglycemia. There will be development of hypoglycemia. Now normally, if this patient was not absolutely insulin deficient, he would have defenses like decrease in insulin, increase in glucagon, increase in epinephrine. But in this patient, beta cells are already lost. We have given exogenous insulin. So these exogenous insulin will not be suppressed. If there was endogenous insulin, there will be first defense, that is decrease in insulin secretion. So there will be no decrease in insulin secretion from the endogenous pancreas, and this decreased insulin from the body is sensed by alpha cells, which increase the glucagon secretion. So this second defense is also lost. Second defense is also lost. So first defense is lost, second defense is lost. At the same time, alpha cells are normally present in pancreas, and these will respond to other physiological stimuli like exercise, but will not respond to hypoglycemia. Now, episodes of hypoglycemia are typically increased during exercise, during sleep, in which the insulin resistance is decreased. Now, what happens is the third defense, which is increased in epinephrine. This is the third critical defense against hypoglycemia. This is also typically attenuated in such patients who have recurrent hypoglycemia. This leads to shifting of glycemic threshold to lower side for the sympathoadrenal response. So there will be attenuated sympathoadrenal response to hypoglycemia. This is termed as hypoglycemic associated autonomic failure. There will be decreased epinephrine release, there will be decreased sympathetic neural responses. This will lead to defective counter regulation, at the same time hypoglycemic unawareness. This will lead to recurrent hypoglycemia, and this will continue as a vicious cycle of further lowering of glycemic threshold. So this is a very deadly situation. These patients are at 25 times increased risk of developing recurrent iatrogenic hypoglycemia. Now, is it same as autonomic neuropathy? Is this hypoglycemia associated autonomic failure same as autonomic neuropathy? No. This is completely different entity. This is a type of neuropathy. It is a structural disorder and irreversible disorder. On the other hand, half is a functional autonomic failure and it is reversible. We will see how to reverse this hypoglycemia associated autonomic failure in the next slide. So how to avoid this hypoglycemia in diabetics? So risk factor reduction of hypoglycemia for patients admitted in hospital who are at most of the risk of hypoglycemia. The goals of blood sugar level should be in 140 to 180 milligram per deciliter. We do not target very intensive blood glucose levels in hospitalized patients who are at the most of the risk of hypoglycemia. Now for patients with diabetes in general, we make a goal to target lower HbA1c levels with no severe hypoglycemia and preserved hypoglycemic awareness. Now, continuous glucose monitoring along with insulin pumps can mimic closely the physiological release of insulin in response to meals, stress, exercise, thus avoiding severe hypoglycemia. Pancreatic transplantation have also been tried for severe hypoglycemia with successful results. Now, what is the treatment of hypoglycemia associated autonomic failure once it has developed? So, just we have to keep a 2 to 3 week period of scrupulous avoidance of hypoglycemia, which reverses the reduced epinephrine component of defective glucose counter regulation. Basically, this avoidance of hypoglycemia for 2 to 3 weeks will bring the threshold for epinephrine release back to normal range. This will bring the threshold for release of epinephrine back to the normal range, that is around 65 to 70 milligram per deciliter in patients who have controlled blood sugar levels. After we have discussed hypoglycemia and diabetes, let's come on to the discussion of hypoglycemia in non-diabetic individuals. So in ill or medicated individuals, the initial diagnostic focus in descending order of importance should be first on drugs which cause hypoglycemia, then critical illnesses causing hypoglycemia, hormone deficiency, then followed by non-islet cell tumor causing hypoglycemia. So first we have to rule out drugs, then some critical illness, hormone deficiency, then we have to search for any non-islet cell tumor which can have hypoglycemia. On the other hand, in seemingly well individuals, the causes include endogenous hyperinsulinism as well as accidental or malicious hypoglycemia. Now we will discuss each of these causes in detail. So what are the drugs causing hypoglycemia? So in diabetics, the most important drugs are insulin secretagogues, which suppress the glucose production and stimulate glucose utilization. When we consider ethanol, this inhibits gluconeogenesis. Now, does it also inhibit glycogenolysis? No. The glycogenolysis is persistent in alcohol users. But why these patients develop hypoglycemia? So hypoglycemia typically occurs in them after several days of ethanol binge during which a person is eating very little food, which leads to depletion of glycogen. At the same time, gluconeogenesis is also inhibited. So these patients can develop hypoglycemia after several days of alcohol binge. Now, other drugs which are implicated includes ACE inhibitors, ARBs, beta blockers, quinolone antibiotics like levofloxacin, sulfonamides, quinine, which is an anti-malarial drug, and NSAIDs like indomethacin. So among ill or hospitalized patients, the most common cause of hypoglycemia is drugs. Now after drugs, we have to consider critical illnesses like hepatic failure, renal failure, cardiac failure, as well as sepsis. So hepatic failure, be it acute or chronic, both acute as well as chronic, can lead to hypoglycemia, as liver is the major site for endogenous glucose production by glycogenolysis as well as gluconeogenesis. That is why in patients with acute hepatitis, we administer frequent oral or parenteral glucose as therapy. Now, renal failure can lead to hypoglycemia. So, as we all know, that kidney is a site of gluconeogenesis. So, the gluconeogenesis will be affected, as well as renal failure will lead to impaired clearance of insulin. So, the insulin levels will be increased, leading to hypoglycemia. Cardiac failure, exact mechanism is not known, but it can lead to congestive hepatitis as well as ischemic hepatitis or hypoxic damage to liver. Then sepsis is a relatively common cause of hypoglycemia in ICU patients. What happens is, in sepsis there is increased glucose utilization, typically in macrophage rich tissues. So what are these macrophage rich tissues? These are liver, spleen, lung, etc. So there is increased utilization by these tissues. There is inhibition of gluconeogenesis. And finally, this can also lead to hepatic renal hypoperfusion if it is leading to multi-organ dysfunction. So again, there will be hypoglycemia. All these mechanisms can lead to hypoglycemia. Obviously, hypoglycemia can also be seen with long-term starvation. In critical patients, after we have ruled out drugs, critical illnesses, then we have to think about hormone deficiency. Although neither cortisol nor growth hormone is critical to the prevention of hypoglycemia, at least in adults, still hypoglycemia can occur with prolonged fasting in patients with primary adrenocortical failure or growth hormone deficiency. So primary adrenocortical failure, which is seen in Addison's disease, this is associated with anorexia, weight loss. These are the typical features of chronic cortisol deficiency and can likely result in glycogen depletion. So if the patient is not taking enough food, there will be glycogen depletion leading to hypoglycemia. Also, cortisol deficiency is associated with impaired gluconeogenesis and low levels of gluconeogenic precursors. When we consider growth hormone deficiency as a part of congenital hypopituitarism, this can lead to neonatal hypoglycemia. These patients present with hypoglycemia, seizures, and other features. Now, finally, there can be some non-islet cell tumors, which are also known as non-beta cell tumors, non-pancreatic tumors. This typically leads to fasting hypoglycemia. These can be seen occasionally in patients with mesenchymal or epithelial tumors like hepatomas, adrenocortical carcinomas, as well as carcinoid tumors. Now, the glucose kinetic pattern resembles those of hyperinsulinism, but insulin is typically suppressed during the hypoglycemic episode. So, what is causing hypoglycemia in these patients? It is basically due to overproduction of incompletely processed big IGF-2 molecule that do not complex normally with circulating binding proteins. So, these molecules circulate freely in the blood and gain access to target tissues, basically in the tissues where insulin receptors are present, and leads to hypoglycemia. So for treatment of this, we have to decrease the tumor bulk. Glucocorticoid and growth hormone have also been reported to alleviate hypoglycemia in these patients. When we consider hypoglycemia in seemingly well individuals, the causes can be endogenous hyperinsulinism or accidental or malicious hypoglycemia. So, the causes of endogenous hyperinsulinism can be primary beta cell disorder, typically an insulinoma, which is a beta cell tumor. Or there can be functional beta cell disorder in which there can be hypertrophy or hyperplasia of beta cells. Other than this, antibody to insulin or insulin receptor can lead to hypoglycemia. Beta cell secretagogue like sulfonylureas ingestion by a healthy adult can lead to hypoglycemia. Rarely there can be ectopic insulin secretion which can lead to hypoglycemia. Now, the fundamental pathophysiologic feature of endogenous hyperinsulinism caused by a primary beta cell disorder or a insulin secretagogue is failure of insulin secretion to fall in hypoglycemia. Now, this feature is assessed by measurement of plasma insulin, proinsulin and C peptides at the time of hypoglycemia. Now, all these are inappropriately normal to high, and plasma glucose is low at the same time. Also, there will be low plasma beta hydroxybutyrate because of insulin, which inhibits ketogenesis, and there will be increase in glucose more than 25 milligrams per deciliter after administration of glucagon. So, these all indicates that there is increased action of insulin or insulin like growth factor molecule in the body. Let's first discuss insulinoma. So, it is an insulin secreting pancreatic beta cell tumor which is a prototypical cause of endogenous hyperinsulinism. It causes fasting hypoglycemia. Incidence is 1 in 2.5 lakh individuals per year. More than 90% of these tumors are benign. More than 99% are pancreatic. Median age is 50 years, but when present along with MAN1, it can present as early as third decade. Now, CT MRI can detect 70 to 80% of insulinomas, but endoscopic ultrasound is more sensitive and can detect 90%. The somatostatin receptor scintigraphy can also be used for diagnosis and exact localization of the tumor. For treatment of solitary insulinoma, surgical resection is appropriate. Diazoxide can be used to inhibit the insulin secretion. It inhibits insulin secretion. Octreotide also inhibits insulin secretion from pancreas. Now, mTOR inhibitor, that is everolimus, has also been successful in combination with the above approaches. Other than insulinoma, diffuse beta cell hypertrophy or hyperplasia, this pattern is known as nesidioblastosis. This can also lead to hypoglycemia, typically fasting hypoglycemia. Now, if this beta cell hypertrophy or hyperplasia is leading to postprandial hypoglycemia, this is termed as non-insulinoma pancreatogenous hypoglycemia. Then post-gastric bypass hypoglycemia can also be postprandial hypoglycemia. This can occur following Roux-en-Y gastric bypass. It also leads to diffuse hypertrophy hyperplasia of pancreatic islets. Basically, it is also a cause of endogenous hyperinsulinism. Other than this, there are certain autoimmune hypoglycemias which can include an antibody to insulin that will bind to the insulin post meal, then gradually will dissociate the insulin. So it can lead to late postprandial hypoglycemia. So this insulin antibody leads to late postprandial hypoglycemia. Similarly, there can be insulin receptor antibody which activates the insulin receptor, basically acts as an agonist on insulin receptor, leading to hypoglycemia. Now, the presence of insulin secretagogues like sulfonylureas, glinides can also lead to endogenous insulin release and hypoglycemia. So, all of these are causes of endogenous hyperinsulinism. Other than this, there can be accidental, surreptitious or malicious hypoglycemia. Surreptitious means factitious hypoglycemia, that patient is consuming the medications uh, for unknown reasons, and this is termed as factitious hypoglycemia, and malicious, that is to harm someone. So to harm someone, someone has injected the insulin or given the sulfonylureas, this can also lead to hypoglycemia. Rarely there can be pharmacy or medical errors which can lead to hypoglycemia. Now, what is the difference between insulin and secretagogue? Insulin and secretagogue. So, exogenous insulin administration will lead to decrease in C-peptide levels. There will be decreased C-peptide levels, while secretagogues will have increased C-peptide levels at the time of hypoglycemia. Sometimes there can be analytical error in measurement of blood glucose. The patient is absolutely fine, but the blood glucose levels are low in the measurement. There can be artifactual errors, that is when we have collected the blood sample, there is continued glucose metabolism by the formed elements of blood like leukocytes, erythrocytes as well as thrombocytes. This occurs due to delayed separation of serum from the formed elements. Now let's come on to the discussion of inborn errors of metabolism which can lead to hypoglycemia. So these usually result in neonatal hypoglycemia but can also occur in adults. So fasting hypoglycemia can occur due to defects in glycogenolysis, which includes glycogen storage disorder 0, 1, 3, 4 as well as Fanconi-Bickel syndrome. Now it is important to note the differences between glycogen storage disorder 1 and 3. Now there will be increased lactate in both type 1 and type 2, but increased lactate in type 1 will be seen before meals. In type 3 there will be after meals increase in lactate level. There will be increased triglyceride in both type 1 and type 3, but the differentiating point is ketones, that GSD type 1 will not have increased ketones, while there will be raised ketone levels in glycogen storage disorder type 3. Then there can be certain defects in gluconeogenesis, defects in fatty acid oxidation like defect in carnitine cycle, beta oxidation, electron transport system as well as ketogenesis. So these all will lead to fasting hypoglycemia in adults as well as neonates. Now certain disorders cause postprandial hypoglycemia, although these are rare. These include errors in glucokinase, sulfonylurea receptor 1, KIR 6.2 potassium channel. So all these mutations will lead to increased insulin secretion leading to endogenous hyperinsulinism. There can be congenital disorders of glycosylation as well as inherited fructose intolerance. So these will lead to postprandial hypoglycemia. Finally, exercise induced hypoglycemia can be seen with increased monocarboxylate transporter 1 in beta cell, which again will lead to increased insulin release from these beta cells. Coming on to the final part, that is approach to a patient with hypoglycemia. So first of all, diagnosis of hypoglycemic mechanism is critical for the selection of therapy that prevents or at least minimizes the recurrent hypoglycemia. So first we have to recognize and document whether hypoglycemia is present or not. So firstly we will rule out any analytical errors, artifactual errors in blood collection, etc. Then at the time of episode, Whipple's stride must be fulfilled. During the episode, we have to collect blood glucose levels, insulin levels, C-peptide, proinsulin, beta hydroxybutyrate. If available, OHA screen, that is OHA levels will also be done. So at this same time, after the sample collection, we will also urgently start treating the hypoglycemia. Urgently, we will also start treating hypoglycemia as it can be life-threatening. Now we have to identify the mechanisms underlying hypoglycemia on the basis of history, physical examination. We'll ask the patient attenders, that is whether the patient was diabetic, was on insulin or other sulfonylureas, etc. If not, whether the patient was ill or admitted in some hospital. We have to rule out other drugs, we have to rule out critical illnesses, we have to rule out hormone deficiencies like Addison's disease, growth hormone deficiency. Then we will move on to the non-islet cell tumors. If the patient is seemingly well, Then we will consider endogenous hyperinsulin, which can be assessed with history as well as physical examination. Now, according to the levels of blood glucose, insulin, C-peptide, we will have certain lab data. Now, let's discuss what all features will differentiate the various causes of hypoglycemia. So, this table will summarize all the causes of hypoglycemia. Suppose a patient is on exogenous insulin, the glucose levels are less than 55, insulin will be more than 3. You have to learn this cutoffs, that insulin cutoff is 3 microunits per ml, C-peptide cutoff is 0.2 nanomole per liter, proinsulin is 5 picomole per liter, beta hydroxybutyrate is 2.7, and glucose increase after glucagon should rise by 25. So this will diagnose all the etiologies. So if the patient has taken exogenous insulin, so insulin levels in the body will be more than 3, but since it is a exogenous insulin, the proinsulin and C-peptide levels will be low. So C-peptide will be low, proinsulin will be low. The insulin will suppress the formation of ketone bodies, so beta hydroxybutyrate will also be low. And after giving glucagon, the glucose levels will rise by 25. Now, insulinoma, non-islet pancreatogenous hypoglycemia, as well as post-gastric bypass, as well as OHs. All this will lead to endogenous insulin secretion. So at the time of hypoglycemia, although insulin is high, but C-peptide and proinsulin will also be high at this time. Again, it will inhibit the ketogenesis, and glucagon can be used for therapy of hypoglycemia. But it is important to note that in OHA patients, OHA screen will also be positive. What about insulin autoimmune hypoglycemia? In this also, insulin levels are more, C-peptide is also more, proinsulin also more, because this is endogenous hyperinsulinism. Beta hydroxybutyrate suppressed, glucagon can be used as therapy, but antibodies to insulin can be identified. Either insulin or insulin receptor antibodies can be identified. Non-islet cell hypoglycemia, which is due to mesenchymal or epithelial tumors, is due to IGF. In this, insulin levels will be suppressed. Insulin levels will be suppressed. C-peptide, then proinsulin, all will be suppressed. So what is causing hyperglycemia? This is IGF-2 molecule, which is not binded to the binding globulins and leading to hypoglycemia by activating the insulin receptor. Glucagon can be used for treatment of hypoglycemia. Again, there will be no antibody or no circulating hypoglycemic agent. So in this way, we can utilize this lab data to find out the etiology behind hypoglycemia. Now, after we have identified the etiology, we have to treat on urgent basis. So urgent treatment should include oral glucose or just giving a candy to the patient. If the patient is not able to chew, we can give IV glucose if it is available. If parenteral therapy is not practical, we can also give subcutaneous or intramuscular glucagon 1 mg. So it is important to note that glucagon cannot be used in chronic alcoholic patients because glycogen stores are already depleted, so glucagon will not act. As well as type 2 diabetics also have a very little role in glucagon therapy, because in this glucagon therapy will also increase the insulin secretion, so it will be of no use. So basically this glucagon therapy is used for type 1 diabetic patients and other patients of endogenous hyperinsulinism, which we have discussed in the chart. Now for sulfonylurea induced hypoglycemia, we can use somatostatin analogs, somatostatin receptor agonist, octreotide, which will inhibit the release of insulin from the pancreas. Then we have to always try to prevent the episodes of hypoglycemia. That is, we have to correct the cortisol growth hormone if it is deficient. We can do surgical radiotherapeutic or chemotherapeutic reduction of non-islet cell tumor. For insulinoma, we can do surgery. So these can be measures which can help prevention of hypoglycemia. So with this, we have completed the lecture. Now let's see you are able to do these questions or not. All of the following are neuroglycopenic symptoms of hypoglycemia except blurred vision, difficulty speaking, hunger or weakness. So as we have discussed that HSP, hunger, sweating and paresthesias, these are the cholinergic or neurogenic symptoms of hypoglycemia. So the correct answer will be hunger. All others are the neuroglycopenic symptoms. Second question, which of the following drugs do not cause hypoglycemia? Gatifloxacin, which is a fluoroquinolone, will cause hypoglycemia. Quinine will cause hypoglycemia. Indomethacin will cause hypoglycemia. Salbutamol does not cause hypoglycemia. So the correct answer will be salbutamol. All of the following are true about alcohol-induced hypoglycemia except ethanol blocks gluconeogenesis, it is true. Ethanol blocks glycogenolysis, it is false. Ethanol levels correlate poorly with plasma glucose concentration during hypoglycemia, this is true, because chronic alcoholism, that is binge for several days, will lead to hypoglycemia, not acute alcohol intake. Then alcohol induced hypoglycemia typically occurs after several day ethanol binge, this is also true. So the correct answer will be option B. I hope I have covered most of the points. Thank you so much.